Hi, everyone, and welcome back to another episode of Amplify. I am one of your hosts, Sam Ashu. Thank you so much for joining TR and I for another episode. Today, we have a special treat for you. We are interviewing Dr. Reuben Strayer, the author of the 2024 May issue on ketamine use in the emergency department. It is a jam-packed interview, as usual. This one actually went over an hour, and we had to trim some of that content, which will now be available for anyone who's a subscriber at ebmedicine.net. That bonus material will be up soon, so be sure to go to the website, navigate to the article, and look for that bonus audio material. Meanwhile, I hope you enjoy this thorough discussion of all things ketamine in the ED. I also want to remind you that ebmedicine.net is your one-stop shop for all CME needs for emergency medicine and urgent care medicine. This month, if you sign up for the complete bundle of all 3 journals, you get the Points and Pearls Year in Review for 2023 for free. That's a $397 value you receive just for becoming a subscriber. It's a downloadable PDF that includes all of those high-yield points from every single one of those issues, bundled into one document. It's an amazing resource, and I can't wait for you to have it by becoming a complete bundle subscriber today. Also, don't forget about the new Abscess course. It comes with a free incision and drainage kit. That's a $60 value you get for purchasing that course, and more information on both of those offers is available today at ebmedicine.net. And now, let's jump into the interview.
Hi, guys. It's great to be with you. I'm Reuben Strayer. I'm an emergency doctor. I live and work in Brooklyn at the largest hospital in Brooklyn, which is Maimonides Medical Center. And I do emergency medicine for now, 20 years. And more recently, I've started a side gig in addiction medicine, which has been really wonderful. I have addiction clinic, do addiction consults. So I kind of wear 2 hats now. And ketamine touches on both of those roles.
Thanks so much for joining us on the podcast today. We are talking about your article. This is the May 2024 article in Emergency Medicine Practice on current concepts in ketamine therapy in the emergency department, which I was very excited to read. I want to start by saying thank you for being the author. Thank you for compiling all of this evidence, and thank you for being on the podcast to talk to us about it. Let's start with just a little bit about ketamine in general. Can you tell us, it seems like the indications for its use are growing on a daily basis. Where are we today compared to where we were, say, when I started residency? Gosh, that was probably 24 years ago.
Yeah, we've come a long way. Ketamine has been around for half a century. It was synthesized to make up for the shortcomings of its predecessor, phencyclidine, PCP, which was the first dissociative anesthetic. Unfortunately, humans who got phencyclidine for painful procedures and surgeries would tolerate the procedure well, but then would become crazy when they would emerge from PCP and anesthesia. So ketamine was developed to affect the same sort of dissociative unconsciousness without the long period of emergence delirium that we still see with PCP, which is used, of course, recreationally and is still available actually as a dissociative anesthetic. I think the trade name is Amaryl and is, of course, used frequently as a veterinary anesthetic, as is ketamine, of course. So that's the origins of ketamine, and it was used originally mostly in operating theater to good effect, and anesthesiologists learned to expect and how to manage emergent psychiatric distress, which is, of course, exactly what we see when we do procedural sedation with ketamine, which originally was introduced to emergency medicine really for use primarily in pediatrics, because children, having a much more open view of the world and a much more adaptable imagination, are much less bothered by psychoperceptual disturbance.
They're into the dragons and the pink elephants, man.
Yeah, exactly. So it's not that children experience fewer hallucinations or incidents of derealization than adults. It's just that they're not bothered by them the way that adults are, which is why psychiatric distress on emergence is so much less common in kids. So that's how we got started with ketamine in emergency medicine. And then we learned that we could use it effectively in adults for procedural sedation. We learned how to manage psychiatric distress and emergence phenomena. And then from there, we started to experiment with ketamine as an analgesic agent in much lower doses, consciousness-preserving doses. And there's now a mountain of evidence that that is safe and effective. And we then started to harness ketamine's unique pharmacokinetics and pharmacodynamics to use ketamine in a variety of different contexts for agitation, for asthma, even status epilepticus. And now we are seeing ketamine's latest trend in its application, which is the use for depression and suicidality. And we may come to ketamine in the emergency department, not quite yet, but maybe one day we'll see ketamine used as an antidote for suicidality. So that's a brief overview of where we've been and where we're going with ketamine in emergency medicine.
Yeah. There is this concept in the article of the ketamine brain continuum. There's a great figure here, the ketamine dose effects continuum on page 4 of the article. Tell me more about that. Now, that kind of spans all indications for ketamine and what kind of response you get based on the dosing. Is that right?
That's right. So the ketamine brain continuum is based on what we know about ketamine across really its analgesic dose range and its dissociative dose range. The 4 stages of the ketamine brain continuum is a concept that I came up with many years ago now, and they're sort of loosely defined and overlapping phases of ketamine's effect. The main lesson, I think, from the ketamine brain continuum is that ketamine has very reliable effects at the very small doses and the very large doses, so the analgesic dose range and the dissociative dose range. But there's a gap in between the analgesic and dissociative dose range where you don't quite know what's going to happen. And you do get a fairly predictable progression that if you understand what that progression looks like, you can understand where your patient is along that continuum, and you can modify your therapy to produce the effects that you want. In very small doses, let's say 0.1 milligrams per kilogram IV, that's analgesic dose ketamine. And we know that ketamine at that dose is going to have very little psychoperceptual effect. It's not going to cloud your patient's consciousness, and it will deliver some analgesia. Maybe not a lot of analgesia at 0.1 milligrams per kilogram. Some people will be adequately analgesed. Some people won't. As you push up the dose to, let's say, 0.2 or 0.3 milligrams per kilogram, depending on how you're administering ketamine, then you're going to see progressively effective analgesia, but you will start to see some psychoperceptual effects. And I call that range the recreational range, because this is where people who use ketamine recreationally, this is often where they want to be. They're hallucinating, but they are very well aware of what's happening to them. They know this is a drug effect. Some people really like it. They find it odd or enjoyable. Indeed, ketamine is used recreationally for this purpose. However, someone who just broke their ankle and came to the emergency department to get it patched up wasn't anticipating a hallucinatory experience, may not be interested in that. And if you're not careful, if you give too high a dose of ketamine for analgesia, you can push someone from the purely analgesic effect into some psychoperceptual effects at what I call the recreational range. In that range, people are still awake, alert, they're conversant. They know that this is drug effect. You can coach them through it. They may not like it. They may love it. But even if it's unpleasant for them, you can generally move them through this phase of the ketamine brain continuum. But the next phase, what I call partially dissociated, is the place where you really don't want to be. A partially dissociated person is not fully dissociated, meaning that they still have awareness. They're not completely unconscious. They're still receiving information from the outside world, where a dissociated patient is not. However, the partially dissociated patient is nearly disconnected, and they may not be able to see, speak, hear, move. They may feel like they're having an out-of-body experience, that they're looking down on themselves from above. They are in what may be described as a K-hole, where they're unable to interact with their environment, and they may have very vivid and sometimes terrifying hallucinations that they are aware of. This is where you want your patient not to be. And there's really two ways to get there into partial dissociation. The first way is the way that most of us are familiar with, which is after you deliver a dissociative dose of ketamine, let's say for procedural sedation. You give a normal-sized adult 100 milligrams of intravenous ketamine. You do your fracture management, and then the patient is emerging from dissociation, metabolizing that ketamine, And although you bypassed the analgesic, recreational, and partially dissociated phases on the way up to get to immediate full dissociation with that big bolus of ketamine, you can't prevent the patient from passing back down through those phases on the way out, which is why psychiatric distress occurs on emergence. That's why they're called emergence reactions. And many of us have seen really scary examples of patients who are terrified in partial dissociation. And if you've completed your procedure and you are waiting for the patient to wake up, you know that you just need to get them through that brief period of partial dissociation. They're going to metabolize through it, and their connection to the outside world is going to return in a few minutes. You just need to see them through that, and you can do that very effectively using a conventional titratable sedative. The other way that you can get there is by giving too high a dose of an analgesic dose ketamine. So if you are too aggressive with your IV pushes of, let's say, 10 milligrams of ketamine, and you just keep pushing 10 milligrams, 10 milligrams, 10 milligrams, and you don't give ketamine a chance to work as an analgesic, you could push someone into either the recreational or partially dissociated phase where you don't want them to be. And in that case, again, if they're distressed, you may want to treat them with a sedative, or you may be able to sort of talk them through it. I guess a third way that I didn't mention is when you're trying to dissociate someone for agitation or for procedural sedation, and you just don't give an adequate dose. And what happens in that case, let's say you're doing fracture management, and you're like, well, I think this is going to be a real quick one.
Yeah.
So instead of giving my 100 milligrams of ketamine, I'm just going to give 50 because I think it's going to be quick. This is a misunderstanding of how ketamine works. And this is why knowing about the ketamine brain continuum is so important. Because if you give 50 milligrams to that patient where you want to dissociate them for fracture reduction, then you could push them not into full dissociation, but into partial dissociation, which is terrifying for some patients. And the way to manage that problem in this case, when you still haven't done your procedure, is to administer more ketamine to get that patient into full dissociation. So that's an overview of the ketamine brain continuum and an explanation as to why I think it's important to understand.
And when we're talking about dosing for different indications, so along this continuum, you mentioned the analgesic dose anywhere from 0.1 to 0.3 milligrams per kilogram IV. This is ideal body weight dosing, actual body weight dosing. What are we using?
It's ideal body weight. Most people, I think, push the dose up on larger patients, but when you're giving an IV dose of ketamine, it's generally dosed by ideal body weight. That's what's recommended. The way I remember that is ketamine is the ideal drug for all indications, so you should dose it based on ideal body weight.
And then the recreational dosing, there's a little bit of overlap there. It starts as low as 0.2 and then continues into 0.5 milligrams per kilogram. The partially dissociative, again, a little bit of overlap, 0.4 to 0.8. And then the full dissociative dose is a milligram per kilo or more IV.
Yeah. It's important to reemphasize that the recreational and partially dissociated phases of the ketamine brain continuum are invented concepts that are really supposed to be illustrative of what happens to people as they progress through these different dose ranges. These dose ranges are highly variable and overlapping. When we're using ketamine for almost any indication, we want one of two places. For analgesia, we want them in analgesic range. For essentially everything else that we use ketamine for, we want the patient to be fully dissociated. And it's important to understand the recreational and the partially dissociated phases as places you generally don't want to be when you're using ketamine for its various indications.
Yeah, so non-therapeutic areas there. When we talk about analgesia, the method for delivering ketamine for analgesic dosing is usually slow push, not a rapid push. The rationale behind that is because the rapid push is something that might result in some kind of unintended consequence. Is that right?
Yeah, when we're talking about analgesic dose ketamine, again, we're talking about 0.1 to 0.3 milligrams per kilogram IV. There are a variety of other ways to administer ketamine. It's absorbed intramuscularly, subcutaneously, intranasally, by nebulization. And the benefit of using these alternative routes of administration is that it slows absorption. And although as emergency doctors, we tend to gravitate towards rapid on, rapid off medications that work immediately and are highly titratable, propofol is a nice example of that. There are a variety of medications where slowing the administration of the drug actually improves its effect. And analgesic dose ketamine is one of those examples because ketamine, although it's relatively short acting as an analgesic compared to a drug like morphine, does accumulate over 10, 15, 20 minutes. So it's not like propofol where it just disappears in a few minutes. And if you have to redose it, you're kind of chasing your tail. Ketamine accumulates, And the slower that you administer ketamine in analgesic doses, the fewer psychoperceptual effects the patient will experience, or the more mild the psychoperceptual effects will be. That said, the analgesic effects will accumulate, which is why when you're giving analgesic doses, it's beneficial to slow the delivery. You can do that in a number of ways. You can just, 20 milligrams of ketamine in 50 cc's of saline and drip it in over 10, 20 minutes. That's a perfectly acceptable way to do it and is a very good way to do it. You can use a continuous drip. I recommend if you're using a continuous drip of ketamine for someone who, for example, has polytrauma and is expected to have a prolonged period of pain, severe pain, that you give a loading dose to get their blood levels up. So 20 milligrams over 10, 15 minutes, and then 20 milligrams per hour. 20 and 20 is something that I've been using for decades. And that's going to work really well for most people. Once you get them on the drip, you can titrate it up if they're having inadequate analgesia. If they're getting a little bit too loopy, you can titrate it down. And for most patients, you'll be able to find that sweet spot where they're very well analgesed with a clear sensorium and they feel good and don't have significant disturbances in perception. So that's one way to deliver ketamine for analgesia, but there are a variety of novel ways that take advantage of that slow absorption benefit. And intramuscular is used in military all the time, 0.5 milligrams per kilogram. It's important to remember that when you deliver ketamine intramuscularly, that it's significantly less potent, meaning that the dissociative dose of ketamine is 1 to 2 milligrams per kilogram IV, but the dissociative dose of ketamine IM is 4 to 6 milligrams per kilogram, simply less potent when delivered by that route. So about 5 milligrams per kilogram IM will work very well. It's a slower administration phase because IM just absorbs more slowly. So again, you blunt the psychoperceptual effects. The way that I'm most excited about using ketamine for analgesia is using a breath-actuated nebulizer. So the way that a breath-actuated nebulizer works, we're all familiar with conventional nebulization. You put some drug into a canister, you attach oxygen, and as soon as you turn on the oxygen, that drug gets aerosolized into a mask and also out into the world. And that's fine, and we do that, for example, for asthma treatment all day long, and there's no problem there. With ketamine, you can nebulize it in the conventional way, and it works. But a couple of problems there is that you're administering a continuous dose of ketamine, not only to the patient, but also into the environment, which your nurses may not appreciate if they're in the midst of, for example, starting a line. It's a pretty small dose, and I think you'd be hard-pressed to think that someone's going to be significantly affected by it who doesn't have the mask on their face. But depending on the patient, depending on what's going on, is it a child, for example, a fair amount of that nebulized aerosol could escape into the environment. With a breath-actuated nebulizer, it's basically a mouthpiece that you put into your mouth and you suck on. What's genius about a breath-actuated nebulizer is that the aerosol is only administered when the patient is taking a breath. When the patient isn't taking a breath, inhaling on that breath-actuated nebulizer, the oxygen may be flowing from the wall, but it's not causing the medication to be aerosolized. And so what that means is two things. Firstly, you don't get this escape of ketamine aerosol into the environment. But more importantly, you have now a poor person's PCA. The patient can administer as little or as much analgesia as they want. So this takes only moments to set up once you have the device in your department. It works very much like a conventional nebulizer. You put, let's say, 100 milligrams of ketamine and some saline into the canister, attach it to oxygen, hand it to the patient, and you say, when you're in pain, you just take a few breaths on this. And so it acts really powerfully as a patient-controlled ketamine anesthesia in that way, kind of like nitrous.
How do you keep them from getting to a subdissociative dose where they're starting to get to that recreational zone?
So it could happen depending on how much you put in the canister. The way that you would manage that is you explain in layman's terms how the ketamine brain continuum works. And you let them know that at low doses, you'll have great analgesia, your pain will be relieved. As you push the dose higher, you'll start to feel funky and you'll start to hallucinate. But a funny thing happens when you give the patient control over that experience, which is that even if they experience psychoperceptual effects, because they know that that's something that they have control over, they don't mind it as much. For example, you give this to a teenager and they're like, all right, bring on the throbbing walls. And they'll, as you would expect, they'll huff on that thing. And that's totally fine. That's totally fine. Many of them love it. Whereas someone else may say, I just want a little bit of analgesia. I don't mind the pain. I don't want to have any distortion of perception. And they'll just take a little bit. And that also is really effective from an analgesic perspective. When you empower patients to administer their own medications in this way, you make them more effective.
And the dosing for that breath-actualized nebulizer is the same as it would be for IV dosing?
No, it's less potent when you give it by ban. There's been a number of dose-finding studies. Many of them have been conducted by my colleague Sergei Motov at Maimonides. And I think that what a lot of people have come to is about 1 milligram per kilogram. It's like 1 to 2 milligrams per kilogram nebulized.
There was discussion in the article about combining it with the effects of some of the neuroleptic medications like Haldol or droperidol. What is the benefit in that scenario, if any?
Yeah, so I'm a big proponent of using the butorphanone neuroleptics for analgesia, and I do it all the time. So Haldol and droperidol are very similar agents. Droperidol is a little bit faster onset, especially by the intramuscular route. It's more potent. I find it to be a little bit more effective for any of the indications that we would use Haldol or droperidol for, but they have the same indications. And if you don't have access to droperidol, Haldol works very well as well. Generally, I recommend that you double the dose compared to droperidol. But for pain of any sort, especially in opioid-tolerant patients, Haldol and droperidol are often very effective analgesics in their own right. This is really underappreciated by emergency physicians, and they don't think of using what they think of as an antipsychotic or a sedative for pain, but they're very effective. Many emergency docs will use them for headache. We know that droperidol especially is really fabulously effective for headache, but it turns out it also works for lots of other types of pain, especially chronic pain, especially pain where there's an emotional component to the pain, and there often is. So for patients who even just come in with, let's say, a broken arm, it's not that I'm not going to give that patient with a bad fracture a dose of morphine. Of course, I'm going to give them a dose of morphine. But if they're really distressed by that fracture, I will augment that with a little bit of droperidol or Haldol, and it makes a big difference. It really calms things down. It provides its own analgesia and cuts through that emotional component to pain. Now, how does this play with ketamine? Really powerfully, because let's say you give somebody 5 milligrams of intramuscular droperidol. You gave them some morphine, didn't do much. This is a chronic pain patient on opioids, and they're in fabulous pain. They came in by EMS. They're screaming in pain with gastroparesis or whatever it is, their chronic back pain. And you gave them a couple doses of morphine. You decided that was the right thing to do, which we can discuss that if that's the right thing to do for that patient. Some patients, yes. Some patients, no. You give them a couple of doses of morphine. Of course, they're taking 100 morphine milligram equivalents per day at home. So your 2 doses of 5 milligrams of morphine just probably isn't going to do much for them. So it doesn't do much for them. And so then you dose them with, let's say, 5 milligrams of intramuscular droperidol, or if they're really not doing well, 10 milligrams of intramuscular droperidol. And what that generally does is it causes that patient to fall asleep, hopefully, and also has an analgesic effect. And what happens often is that patient falls asleep for an hour or two. They wake up, they feel better, and they want to go home. If that doesn't happen, you are then really well set up for ketamine analgesia, which you can administer in a larger dose and a little bit more quickly, because even though that larger, more quickly delivered dose of ketamine is going to bring more psychoperceptual effects, they will experience those psychoperceptual effects that you cause with that larger dose of ketamine, let's say 30 milligrams over 15 minutes. They're going to experience psychoperceptual effects, but because they just got 10 milligrams of droperidol, they just will not be bothered by those psychoperceptual effects. So what you've done in essence is you've widened your therapeutic window for ketamine. And that's really ketamine's major weakness as an analgesic agent, is that it can be a little bit difficult sometimes in some patients to find that sweet spot where you have adequate analgesia but no dysphoria. Some patients, like they're in pain, and then you get on top of their pain with ketamine. You kept turning up the drip, and now they feel pain-free, but they're dysphoric, and they're like, okay, my pain's gone, but I don't like the way that this feels. Can you just turn this off? I don't like this. And so sometimes it's hard to find that sweet spot. In that case also, for example, let's say you've turned up the dial on the ketamine drip. Your patient's pain is gone. They got this terrible burn or whatever it is. They're in severe pain. You get them on ketamine. Their pain's gone, but now the walls are throbbing, and they're like, Doc, I'm not into this. Give them a little bit of droperidol and see what happens. And you kind of smooth things out. They might fall asleep for a little bit, and things just calm down, and they're well analgesed, calm. And that's how ketamine and butorphanone neuroleptics work together.
Perfect. I like that.
As kind of a follow-up to that, because I'm starting to do more and more ketamine for pain, when you're giving it to people, someone that's in, a significant amount of pain, moderate to severe, are you starting low and trying to titrate them up? Are you giving pushes, or are you more often going to drips? And do you start at 0.1? Do you start at 0.2, or do you try 0.3 off the bat?
So for most patients where I'm reaching for ketamine, I'm using a slow loading dose and a drip for most patients. If this is a patient that I think is just going to leave the emergency department in an hour or two, these are not the patients I'm generally reaching for ketamine. And it's the patient that is going to be admitted, the patient who's going to be around for a while. The most frequent time that I use it is actually not when opioids aren't indicated, it's when opioids aren't working. For example, the patient with polytrauma who's in severe pain, I'll give my dose of zero point 0.1 to 0.15 milligrams per kilogram of morphine, and then I'll often give one more dose like that. But if after 2 doses, if they're not experiencing significant pain relief, or if they're experiencing significant side effects from the morphine, which some people do, some people get really nauseous from morphine. Some people really don't like how parenteral opioids feel. I'm putting on my addiction hat here, but like there's a lot of people out there, and I'm sure you've encountered them, who they're like, my doc gave me Percocets. I took a Percocet. I felt like crap. I didn't want any part of that. So I've given my 2 doses of IV morphine to someone in severe acute pain, and they're like, okay, I feel a little bit better, but I'm still in severe pain, and now I'm vomiting from the morphine. That's the time to be like, okay, morphine is really not doing the job here. Reach for ketamine. So in that case, I'll generally give 20 milligrams over 10, 15 minutes. I just put it in 50 cc's and drip it in over 10 minutes, and then I set up my drip. 20 to 30 milligrams per hour, titrate up and down. That's the classic way that I've been using ketamine for many, many years. At my shop, I do have access to a breath-actuated nebulizer, and I've been using that as well, really to fabulous effect.
We're seeing more and more patients on Suboxone and Subutex where, they're like, hey, I'm already on this. Like, I don't want opiates. And I'm always trying to figure out new creative ways to handle their pain when they have some kind of significant injury.
I do a lot of speaking on how to manage pain in patients who are maintained on buprenorphine. And the mainstay of treatment for patients with acute, moderate to severe pain who are on buprenorphine maintenance for opioid use disorder, the mainstay is non-opioid analgesics. And of the non-opioid analgesics, the one that works the best for severe pain is unquestionably ketamine.
All right, let's touch on procedural sedation for just a little bit. This is, I think, an area where most of the listeners and the two of us are also more accustomed to using ketamine. I feel like we overcame the hurdle of children needing an IV for procedural sedation ages ago at our particular institution, but there are still some places out there that battle that. And ketamine, I think, has a very proven safety record for IM dosing in children, especially, but also in adults. That practice was abandoned at our institution. That's something that you advocate for as well, right?
Absolutely. Interestingly, at my institution where we use ketamine for PSA in children all the time, our protocol absolutely has our nurses establishing an intravenous line prior to PSA. I think this is a poor practice, frankly. Putting a line in a child is not a benign procedure. It's not only is it often difficult, it's quite traumatic to many children. And I think we undersell how important that is. If you have a very sick child and you need to administer intravenous treatments for respiratory failure or whatever it is, of course, start your line, obviously. But these are often elective procedures where you can take your time, and we really should be doing better to be as ouchless as possible in children. And I am ketamine for PSA in dissociative doses, so 4 to 6 milligrams per kilogram. We know with a high degree of certainty, with robust evidence over decades, that this is safe and effective. Some providers are just not going to be comfortable doing PSA without a line. If that's you, you should use ketamine to effect dissociation intramuscularly first. So give your dissociative dose of ketamine. And then instead of pulling on the wrist or whatever you want to do, the first thing you can do after the patient dissociates is then start your line if you need to have a line. I think that people who do this, they see how effective this is, and starting the line takes as long often as doing the procedure. And so they'll just abandon the line. But if you just feel like you need to have a line, then yeah, go ahead and dissociate the patient first. This does 2 things. First of all, it means the patient won't experience pain or memory of a traumatic procedure, which is highly valuable. Also, it's much easier to start a line on a child who's not in pain and thrashing and scared. So you're much more likely to be successful. Some people will say, and it's not untrue, that there is a very small chance that they're going to need to, in a dissociated patient, immediately administer a paralytic. And although this happens very, very rarely, and I suspect neither of you have seen this.
I got one in rural Colorado where I was the only doc there, and it was one of the top 5 scariest things I've seen.
Yeah. So did the patient become super rigid?
Super rigid, locked his jaw, like little, 5-year-old kid with a fracture that I was going to splint. And I sedated him. I am ketamine, and he really locked up and went into like real laryngospasm. And he broke when I did a good jaw thrust, but it was still, it gave me pause about doing it. And I tend to be a lot more careful now.
Mm-hmm. So when you gave the jaw thrust, he started breathing again.
Mm-hmm.
Did you need to do anything else?
Didn't need paralytics, just a good jaw thrust. And then I think I had gone not super high. I think it was 4 mgs per kilo. And we bagged him, and like basically the rigidity kind of gradually come down, and he didn't need to be paralyzed. But I had the meds there. And I was thinking about it, but it didn't need it, but it still was very, very frightening.
100%. What you're describing actually is not that uncommon. I was describing the need to paralyze and intubate. That's distinctly uncommon. But hypoventilation and maybe from laryngospasm in this case, this is not that uncommon and is very important, maybe the most important thing to know about ketamine. And I emphasize it repeatedly in the paper. But yeah, so if you feel like you are uncomfortable with a dissociated patient who doesn't have a line, what I would say is go ahead, do your IM, start your line afterwards, or you can have a dose of IM succinylcholine available if need be. This, in my view, is the only indication for succinylcholine over rocuronium, which is that rocuronium does not work effectively intramuscularly, whereas succinylcholine does. So if you just must have that dose of paralytic, and I wouldn't fault you for thinking that, just have a couple of vials of sux at bedside ready to be drawn up and administered if need be. There's also IO, right? You can place an IO in 10 seconds and administer rocuronium or a succinylcholine. These are really rare events. So that's how I think about IM versus IV ketamine, especially in pediatrics for PSA. I think that having as a routine, starting a line before administering ketamine for PSA in kids, I think this is inferior practice to starting with IM.
Okay, I want to focus on treating a patient who was agitated in the field, not from polytrauma. Let's say it's medical. We don't really know if it's substance related or psychiatric or what the occurrence was, but it wasn't a trauma patient. And they were given ketamine for agitation in the field by our EMS colleagues, and then are brought now to the emergency department, and you're faced with someone who is calm and unconscious, appropriately responded to the ketamine, but someone who you didn't have the benefit of examining before the ketamine was delivered, in addition to putting them on the monitor and making sure they're in the appropriate setting, monitoring their breathing and their capnography. Are you always going after neurodiagnostic imaging, like CT imaging of the brain in that scenario, because they are now sedated and you have no exam? Or are you relying on what the EMS colleagues told you happened pre-hospital and then waiting to see how they behave and how they perform after the ketamine sedation is passed?
Important question. And I think the answer really should be the latter. We rely on our pre-hospital providers' assessments routinely, as we should. The medics don't know what was going on. This guy came at them and then there was just there's no real history where you have no idea what's going on. It's very reasonable to send that associated person to head CT because you have no history. It's very different when the family called EMS because their mentally disturbed son has just been becoming progressively agitated over the past 6 hours and then started throwing chairs around, and the police and EMS came in and they had to deliver a dissociative dose of ketamine. In this case, it is very reasonable, assuming there's no trauma on the body, to allow the patient to emerge from ketamine. It shouldn't take that long, 15 minutes, 30 minutes. If their vitals look otherwise okay, they're breathing. Again, you have them on capnography. You have an airway-capable provider at bedside or immediately available, as we just discussed, and you let them emerge from ketamine and just sort of see where you are. This, in many cases, is similar to the unconscious drunk that we manage 20 times per shift, on an overnight shift. And so if the unconscious drunk comes in, you have no exam. Generally, I think most emergency docs manage this, is if there's any evidence of head trauma, we send them through the CT scanner. If not, we wait. We just watch. And if things progress as we anticipate, and 99% of the time they do, then you've saved that patient a CT scan. You've saved that resource for patients who might need it more. If the patient doesn't progress as you anticipate, then you act on that and you expand your diagnostics. So that's how I think about the patient who arrives GCS3 from ketamine. We call that GCS3K. All dissociated patients are going to be GCS3. This is not an indication to intubate, assuming that they're otherwise doing well from a ventilation perspective, which most of them are. But this is certainly not the patient you stick in a corner and allow to emerge off monitor. No, all patients who are dissociated need to be in resus or with some sort of resus level monitoring in place for the duration of their dissociation, which means you're watching, in this case, ventilation is really where the money is, and you're watching ventilation like a hawk, either using room air pulse oximetry, or if you're providing oxygen, capnography.
In the article on page 8, there's a fantastic figure there about the relationship between RSI, delayed sequence intubation, and ketamine-only breathing intubation. Can you just briefly walk me through that decision-making about when you might elect to do something like ketamine-only breathing intubation?
Yeah, sure. So these are 3 different techniques that have 3 different indications. They're overlapping, but are distinct. RSI, I don't think I need to say as much about because that's our bread and butter. The reason to consider alternatives to RSI is when you have special circumstances that dictate that you should consider those alternatives. DSI and ketamine-only intubation are related but different techniques. Delayed sequence intubation, as popularized by Scott Weingart many years ago, has to do with deferring paralysis for a period of preparation. Delayed sequence intubation, DSI, can be thought of as procedural sedation for the purposes of preparing to intubate. The reason to do DSI is you've identified that a patient needs to be intubated, but they are not allowing you to adequately prepare, which includes pre-oxygenation, most important, but also getting a line, setting up your equipment, doing your proper airway assessment. They're not allowing you to do that for agitation. Agitation, perhaps because they're intoxicated, perhaps they're hypoxic. And so the COPD patient who's satting in the 50s, ripping off their face mask and not allowing you to pre-oxygenate them, this is a pretty scary patient to RSI. So don't do it. Don't do RSI. In this case, it's really not safe. You do DSI, which is the administration of a dissociative dose of ketamine. Other people recommend a different approach. So Scott, for example, recommends small aliquots of ketamine. I've long differed with him on this. I think both approaches are safe and effective. I just don't see the benefit of a smaller dose. I'm not interested in like the smallest possible dose of ketamine. I'm interested in causing reliable full dissociation. So I have the opposite view, really, which is that you want to give a dose that you know is going to dissociate the patient. And if it turns out to be a larger dose, in my opinion, this has never been demonstrated to be of any consequence. Some people will say that excessively high doses or higher doses of ketamine than you need are more likely to cause hypotension. I don't think that this has been demonstrated. And in any case, it's a trade-off because underdosing your patient with ketamine has its own risks. I recommend a full dissociative dose of ketamine, which you administer to that, for example, COPD patient, satting 50%, ripping off his face mask. You give a full dissociative dose of ketamine. Now the patient is dissociated, awake but unconscious. You put that patient back on the face mask, or even better, on non-invasive ventilation. Okay, now you're in business. SATs are coming up. You get your line. You prepare everything. It's been 3, 4, 5 minutes. Everything is in place. Patient's SAT is 100%, and you are now well positioned to do the rest of the procedure, which is administer 100 milligrams of rocuronium, and then 20 seconds later, you can lower the head of the bed, take the non-invasive off. Ideally, you've put a nasal cannula on beforehand to do some apox, and you can go ahead and intubate. So that's delayed sequence intubation. It's procedural sedation of a patient that you're about to intubate for the purposes of preparing to intubate. It has a fairly narrow, but I think really important set of indications, which is the agitated patient who won't allow you to adequately prepare and pre-oxygenate to intubate. Ketamine-only breathing intubation is a different technique that has a different set of indications. COBE has the word breathing in the name because what we're doing is we're keeping the patient breathing during intubation. This is more conventionally called awake intubation. I disfavor that term because the patient is often not awake. And so I think it confuses people. Now, you can do awake intubation with the aggressive use of topical anesthetics, lidocaine delivered by nebulization, atomization, regional nerve block. And anesthesiologists upstairs, they do this all the time in these difficult airway cases. They'll take 30 minutes to prep the patient's airway with a local anesthetic. And then using either laryngoscopy or flexible endoscopy, which is often referred to as fiber optic bronchoscopy, they'll use a flexible endoscope in a highly topicalized patient who is in fact awake and has a normal mental status. And this, of course, is an extremely safe way of intubating someone because they're completely awake and they are breathing and able to manage their secretions and maintain their airways. And that's a conventional awake technique. It's often called awake tracheal intubation by anesthesiologists, ATI. I prefer to call it topicalized awake intubation because I think that describes it the best. And it's a great technique, and I would love it if all emergency physicians were familiar with that technique. But there are a number of problems with that technique for emergency medicine. Firstly, this technique is poorly taught in many emergency medicine residencies, so many emergency physicians are not comfortable doing a full topicalized awake intubation. Secondly, TAI requires that the patient be on some level cooperative. And also, you need to have some time, especially if you don't do this very often. So it requires time, it requires patient cooperation, It requires a set of materials that may or may not be present in your department, like atomizers to deliver topicalized lidocaine. And then it requires that skill set and maybe a flexible endoscope, which may or may not be available. COBE, ketamine-only breathing intubation, offers some of the safety of a topicalized awake technique, meaning that the patient usually will continue to breathe during intubation using a skill set that is already present in emergency physicians that emergency docs already have, and using materials that are readily available in all emergency departments. So you basically use the skill set of RSI while gaining some of the safety of topicalized awake. That's the benefit of ketamine-only intubation, where you deliver a dissociative dose of ketamine. Now the patient is dissociated, which means that they will relatively well tolerate laryngoscopy, usually, not always. One of the things we love about ketamine for procedural sedation is that airway reflexes are preserved. However, in this case, they are unwelcome because after you've delivered your dissociative dose of ketamine, your next move is going to be to jam a laryngoscope into the patient's mouth. They're not aware of it because they're dissociated, but they still have their airway reflexes and they still have muscle tone. So you may see some gagging and some coughing. And more importantly, I think emergency physicians are used to doing laryngoscopy on paralyzed patients, which is very easy. Most emergency physicians have not intubated non-paralyzed patients. If you don't paralyze, laryngoscopy, exposing the cords and delivering the endotracheal tube is significantly harder. And many emergency docs are not prepared for that. So you have to know that if you give 100 milligrams of intravenous ketamine over a couple of minutes and the patient is not dissociated, you put in that laryngoscope, you may get a little bit of gagging, you may get a little bit of coughing, and also you're just going to have to work harder to get that good view of the cords. But there's much less urgency because the patient is breathing. So if you have to readjust, if you have to come out and try again, if you want to change blades, you want to change patient position, all this is done in a very low drama way because the patient continues to breathe, the SATs are 100%. So that's the benefit of a ketamine-only approach. The reason to do a ketamine-only approach is when you are especially concerned that paralysis will harm the patient. And that occurs in two scenarios, broadly speaking. The first is anatomic difficulty. The second is physiologic difficulty. Anatomic difficulty is your run-of-the-mill patient with a vocal cord tumor, the patient who cannot move their neck, the patient who has no neck, the patient who is known to be a difficult intubation. And they tell you, they almost had to cut my neck last time they tried to intubate me because I'm a very difficult intubation. This is someone that you don't want to paralyze. You're not going to administer a paralytic to a patient where you're very concerned that laryngoscopy is going to fail. This is probably the strongest case to try to keep the patient breathing during intubation. The safest way to do that is with topicalized awake. But if that's not a good option for the reasons we just discussed, ketamine-only gives you some of the safety benefits of topicalized awake using speed and technique that emergency doctors are comfortable with. A second indication for ketamine-only is physiologic difficulty, in particular, the patient where you're concerned that even a very brief period of apnea that you would get from a paralytic would be extremely dangerous to the patient. So the patient who is profoundly hypoxic and is satting very poorly, even with maximal oxygenation therapies, or the patient who is profoundly acidemic from very bad DKA, toxic alcohol, whatever it is, and you're worried that a brief period of apnea is going to send that pH from 6.9 to 6.4, which will precipitate arrest. And in those patients, you do better to keep them breathing during intubation, and ketamine-only is an effective way to do that for many emergency docs.
There was a brief discussion in the article about patients with certain medical conditions that might preclude you from using ketamine. For example, those that might be particularly susceptible to that catechol surge that you're going to may get, I should say. So in general, the ones that are listed in the article were things like people with hypertensive pulmonary edema, perhaps acute myocardial ischemia, those with subarachnoid hemorrhage, or those that are actively dissecting their aorta as categories of people who might not be the ideal choice for ketamine intubation, regardless of the type that you're performing. In general, are you tending to shy away from ketamine in those categories of patients?
Yes, fairly reliably in patients who are not already catecholamine depleted. Ketamine is a weak catechol and will cause an increase in blood pressure and heart rate in most patients. We see this robustly in PSA. And we see it often in critically ill patients, although less often in critically ill patients because many of them are catechol depleted. But in patients where you do not want to see an increase in heart rate and blood pressure, then do not use ketamine, because ketamine will often cause an increase in heart rate and blood pressure. And we have many other agents. If the problem is psychomotor agitation, the ketamine will cut that and the blood pressure will come down. But for the patient who is very hypertensive, or when you just don't want to see any increase, the untreated subarachnoid with a blood pressure of 130, well, you're okay. 130 might be all right, but you don't want to see 170. Ketamine is the wrong choice for that patient. Use etomidate, use propofol if you are really ready to deal. You would get like a drip going at the same time that you push propofol, but avoid ketamine in those circumstances.
And then some of the contraindications that have been debunked with literature and a good scientific base now are things like ketamine increasing intraocular pressure or increasing intracranial pressure.
Correct. Those are classic contraindications to ketamine that we know are myths, and you don't have to be concerned about that. In fact, the head injured patient is a fantastic indication for ketamine because nothing is more harmful to a brain injured patient than hypotension. And ketamine is the induction agent that is probably least likely to cause hypotension.
All right. So we touched on analgesia, procedural sedation, agitation, and RSI. There were mentions of some other indications that you might consider ketamine for, asthma being one of them for the severe asthmatic. There is evidence there to show that that's of benefit with patients suffering acute bronchospasm.
Yeah, so ketamine has a long history of use in the management of severe asthma. Unfortunately, the data demonstrates that this is by no means a magic bullet. And I think it's reasonable to use ketamine at the end of your therapeutic armamentarium in a patient where you're getting ready to intubate that patient. And if you get everything set up, you can use a dissociative dose of ketamine. Subdissociative doses have been repeatedly demonstrated to be ineffective in the literature. The data around dissociative dose ketamine for asthma is mixed. We are not talking about a strong record of efficacy in the literature. That said, there are lots of low-level evidence reports of a patient who everyone was getting ready to intubate. They got a dose of ketamine and the patient chilled out and improved, and they didn't need to intubate that patient. And that's very powerful because, as we know, intubating the asthmatic doesn't solve the problem and, in fact, often just makes the problem worse. So if you can avoid intubating an asthmatic, you've done a great service to that asthmatic and to your underwear. Using ketamine in that way makes a lot of sense as a last-ditch therapy when you're all set up to intubate, recognizing that the patient may improve and just may get better. There's a variety of speculated reasons for that. It might be that ketamine has direct bronchodilatory effect. I tend to favor another explanation, which is that ketamine causes the breathing to slow down because it untethers the patient from air hunger. And it's the slowing down of the breathing that actually is the treatment that they needed to break the vicious cycle of air trapping and bronchospasm. So the way you would use this, in my view, is you've already treated the patient with continuous nebulized bronchodilators, magnesium, steroids, all the things that you normally treat your severe asthmatics with. They've failed non-invasive. You're getting ready to intubate. You then deliver a dissociative dose of ketamine over a couple of minutes, and you watch like a hawk, and you see how they are. And if they improve, lovely. If they don't, you do what you were intending to do anyway, which is 100 milligrams of rocuronium and endotracheal intubation.
Okay. And then there is the indication of status epilepticus, but this is not as a first or second or maybe even third line agent. This is your last ditch effort after they've already failed everything else that you have available to you in the ED. Is that correct?
Yeah, I think that's where we are with ketamine for status right now. Again, this is fairly low-level evidence that patients who have failed first, second, third-line agents respond to ketamine. So just know that it's out there. This is hopefully something you'll be doing in conjunction with intensive care or neurology. These are obviously very sick patients who are in unremitting status epilepticus, which is extremely dangerous. Just recognize that dissociative dose ketamine, often delivered as an infusion, is a treatment that has been demonstrated to work in therapy refractory status epilepticus.
And then also a discussion about its use in potentially alcohol withdrawal syndrome. Again, this is for patients who perhaps have failed benzodiazepine, then phenobarbital, and maybe even propofol before you move on to something like augmenting with ketamine.
Again, very weak data here. This is the end of your toolkit for alcohol withdrawal. I think the best way to think about ketamine for alcohol withdrawal is to understand that it probably doesn't make things worse. It may make things better. And so if the patient is too agitated to allow for proper alcohol withdrawal management, this is a great way to think about ketamine. It really is a treatment of agitation secondary to alcohol withdrawal. Of course, the dissociated patient may stop moving, but you're not treating the pathophysiology effectively with ketamine. So it should never be used in place of GABAergic agents. In the worst case, this is something you would give to treat agitation at the outset of care, immediately augmented by your conventional GABA agents, benzodiazepines, barbiturates, propofol. And then in really bad treatment refractory alcohol withdrawal, the answer is probably to give more GABAergic agents, but you can consider a dose of ketamine as sort of a lower level, reaching for all instruments in my toolkit kind of approach.
All right. And then lastly, let's touch on treatment-resistant depression. So there is a literature base for this outside the emergency department. But when it comes to ED use, you mentioned earlier at the beginning of our discussion that future utility might be the acutely suicidal patient. And this might be something we could use as a temporizing measure. That's a growing body of evidence.
Yeah, I think this is more in the future directions category. Certainly, as an emergency physician, this is not something that I would be doing outside of a protocol, outside of a research study, outside of collaboration with psychiatry. But there is now a very substantial body of evidence that ketamine is an effective treatment for treatment-resistant depression. This is all outpatient and inpatient literature, not emergency department literature. There is some light evidence, case series, I believe, is the extent of it, that ketamine can be used to abridge suicidality acutely, even in the emergency department. I've only seen this done by psychiatry, but it may work, and it looks like it does work for many patients. This is potentially really impactful because America is in the midst of a tremendous shortage of inpatient psychiatry beds and psychiatric services more generally. And holding a suicidal patient for an inpatient bed in many venues sentences that patient to be confined to an emergency room, often for days, which is terrible. So the prospect of being able to acutely treat suicidality and make the patient feel better and make the patient safe for outpatient management is a huge win. And just that prospect alone, I think, is reason that we should know about ketamine on the horizon as potential treatment for depression and suicidality. But this is a treatment modality that is presently peripheral to our role as emergency physician.
Fantastic. Well, we are at the end of our discussion. Is there anything that we didn't touch on that you wanted to be sure to mention?
I think we've had a pretty extensive coverage of what we needed to talk about. So thank you for that. Remember one more time that any dissociated patient who is not intubated is at risk for hypoventilation and apnea. So must be monitored vigilantly for that with an airway capable provider at or near bedside. This is really how you can run into trouble with ketamine. Ketamine has received a lot of attention in the lay press in connection with excessive force by police. And so this is something that all of us need to be experts in, and we all need to know how to use ketamine safely as a really powerful tool in our toolbox across a variety of very common emergency department problems. So I really appreciate this discussion with both of you today. Thanks a lot for having me on.
Thanks, Reuben.
Thanks, Reuben.
And that's a wrap for this month's episode. Thank you for joining TR and I hope you found it educational and informative. Don't forget to go to ebmedicine.net to read the article and claim your CME. And of course, check out all 3 of the journals and the multitude of resources available to you, both for emergency medicine, pediatric emergency medicine, and evidence-based urgent care. Until next time, everyone, be safe.